All right. Are you guys able to hear me? I got a new computer, so I got to check everything out and make sure everything's working tonight. So if there's any hiccups, just let me know.
Yep.
Perfect. We'll give it a couple more minutes just because we're waiting on a couple people. So we'll say about 6:03. We'll kind of get moving here. So. All right, ladies and gentlemen, we'll get moving here. Um, this is the second part to chapter 15 that we're going to cover. So this one has to do more with advanced airway management, and I know that we've kind of played around with intubation already with the skill of it, and we've played around with laryngoscope handles and ET tubes, and this is going to cover kind of the basics of it and why we're doing what we're doing as far as equipment wise. The different parts of laryngoscope, the blades, Mac versus Miller, some of our extraglottic airway devices like LMAs, King LTs, just what we have to do if we have to maintain somebody's airway. What are some indications that we have to essentially take over an airway for somebody for intubation? I guess what would be some reasons we would do that?
Respiratory failure.
Okay, respiratory failure.
Allergic reactions.
Let's back that up with something. Respiratory failure and the patient essentially just struggling to breathe. One of the hallmarks when we're talking about patients in respiratory failure where we have to look at intubating them is their inability to breathe. Or if you've never had a patient before, heard them say before, is that they're getting tired. If your patient gets tired of breathing, that's a pretty bad sign. What else?
Burn victims.
Burn victims, okay. And why are we looking at intubating burn victims?
Some of them, if they have burns to the airway or nasal passages, they may start to close up. You might want to intubate.
Yeah, so in our trauma situations, right? We see the singed nose hairs. That's a pretty telltale sign that this person might have some sort of upper airway burn, and what we're concerned is there is edema and losing that airway entirely. What else?
Allergic reactions, angioedema.
Okay. Yeah. So again, upper airway swelling, tongue swelling, angioedema, severe anaphylaxis. Sure. The real big broad term to cover everything is inability to maintain their own airway. I mean, in the grand scheme of things, that's why we're doing it. Is this patient can no longer manage their airway, so we need to take it over for them. So does anybody service on here? Does anybody carry LMAs by chance? LMAs made like a introduction to EMS for like a brief, I'm not kidding you, maybe a year span. And it was the hottest thing to ever come out with upper airway management, kind of like King LTs did over combi tubes. And then they kind of faded out. Then people realized, they're really not as good as we think they are. They have a tendency to actually back away from where they're supposed to be. And as you can see in the picture there, all they do is essentially isolate the trachea away from anything else. So you insert it like you normally would a King device, except you've obviously got a lot broader face piece on or mouthpiece on it now. And you insert it till you can't go, and you inflate the cuff and hope that it seals. It's a blind insertion device, but the problem was it wasn't always sealing the way it should have. And you still had the chance of leakage and the chance of aspiration. And that's what they were seeing in our patients. They still used them operative-wise, like OR. They'll still use LMAs every now and then, but pre-hospital, they've kind of gotten away from them. And we've went to eye gels, and still have our King LTs as backup. Eye gels, obviously, still an extraglottic airway device because we're still above entering the vocal cords at that point. But they're a lot easier to insert. There's no inflation. They have that gel coating on the edge of them that really relies off the patient's body heat to seal it. And again, you'll see those in same-day surgeries, maybe, especially when you guys do your rotations in like, gosh, I can't think of the unit's name right off the top of my head. But yeah, your same-day surgeries, you'll see that where they don't want to intubate the person and have them, in phase 1 recovery or anything like that on a vent. So that's when we would use those devices. Single use, they're one and done. I've never seen a service that cleans them or disinfects them or anything like that and reuses them. That's nasty. They're cheap enough. But the end all be all for paramedicine is the ability to intubate our patients. And we have to be very careful about which patients we intubate because we can cause more harm than good. There's studies out there showing right now, and for a long time, even 2 years ago, there was a big push that paramedics should not be allowed to intubate because our success rate nationally is absolutely horrible as far as intubation goes. And it's maybe not that our success rate, that the ability to pass the tube is horrible. It's the fact that we can't manage it. It's the fact that we weren't checking and double checking these tubes when we were intubating patients. Maybe we moved them from the house to the ambulance, the tube came dislodged, and by the time this patient got to the hospital, they were so hypoxic that they had severe brain damage. I don't know. I can see either way on how that goes, but with intubation, obviously, I kind of showed all of you guys, if you were able to make it to skills, what we're really looking for as far as it goes trachea-wise, is we're looking for those 2 white bands on either side of our vocal cords, just past our epiglottis. When we're looking in with a laryngoscope, and I'm talking the manual way with a Macro-Miller blade, that is direct visualization. If you're using something as a King Vision or a Glide Scope or a McGrath, that's not direct visualization because you're watching it on a screen. And technically, direct visualization is a way of verifying tube placement. So be kind of careful with how you word that. It's great because it is total isolation from the airway. We're inserting this balloon into the trachea, inflating it. Nothing is getting past that at that point if we do it correctly. And we have optimal ventilation as long as we don't push the tube down further than it needs to be. If we happen to push the tube down a little bit further, what happens?
You're intubating the right main bronch. Yep.
Yeah, it's a right main stem.
Main stem.
Yeah, right main stem intubation. For the simple fact, just based on anatomy, that our right lung travels straight down from our trachea, as to where our left lung kind of branches off from our carina, which is the area where our trachea meets our bronchus. Again, select your patients carefully. And what I mean by this is there are some patients that I will opt not to intubate. If a doctor wants to intubate them, that's his call. Just for the simple fact that I don't know if this patient's going to come off the vent. Maybe it's a patient in respiratory failure that's really struggling to breathe. One of the ones I can think of right off the top of my head is a guy I had in his 90s that, I mean, his end tidal was through the roof, like almost 100. He was really struggling to breathe. And he did not want a tube down his throat. He very specifically said that. But at the same point, I don't know if I would have done it anyway, because he might not come off the vent. We don't intubate people in the most sterile environments, to be honest. And I don't care how clean the back of your ambulance is, it's truly not sterile. We do it in people's houses, we do it in niches, very tough areas that people aren't used to. So again, be careful with your patients. And in that instance, I was able to maintain that patient with CPAP until they got to the hospital. They were going to intubate him, and again, he said he didn't want a tube down his throat, so they ended up leaving him on CPAP for the duration until they could correct his labs. So it's a skill that we need to practice regularly. When I say practice regularly, I don't mean go out and intubate every single patient that you pick up. Even if it's doing something like we do in skills lab, getting out an airway mannequin, visualizing what you're supposed to be going for. The muscle memory, just you get from that and knowing where to place the blade should be pretty good. And you're not going to get every single intubation that you attempt. It's impossible. There are going to be some that are very hard to get, or that it's a tough airway. And you might end up going to a backup device such as a King LT or a LMA or an iGel, just for the simple fact that you can't visualize the chords. And remember, that's a contraindication to intubation itself, is failure to visualize the chords. Always have your backup ready. If I'm going to intubate somebody, I have my airway kit out. My airway kit also has my King LT in it. I have it to where, I have somebody with me that can rip it open real fast. The protocols that I've written, if I'm going to RSI somebody, I have to have at least 2 paramedics there. Is that always going to happen? No. But if I have the ability to have 2 paramedics, then I need to have them both there. Because if I'm drawing up drugs and I'm intubating this person, I need somebody to verify what's going on with me. I need to have another advanced level provider that can really truly understand what's going on. And you'll start, in some protocols say that. Again, it's not always possible to have that, and we get that. But it is preferred to have 2 paramedics generally if you're going to RSI somebody. So some reasons, obviously, for oral tracheal intubation. And when we, like on FISDAP, you'll notice it is called direct oral endotracheal intubation, OETI. It is for patients in either potential cardiac arrest that obviously cannot maintain their own airway because they are clinically dead, or respiratory arrest or extreme respiratory failure. Know the difference between respiratory failure and respiratory arrest. Respiratory failure is the patient starting to trend downwards. As to where respiratory arrest is, we've lost all ability for this person to ventilate on their own. Some of our tools. So our laryngoscope is our handle and blade that we are using to actually visualize the chords when we are intubating somebody. So we're trying to lift the tongue out of the way to visualize maybe the epiglottis, and we know we have to go a little bit further than that to visualize the vocal cords. And then we have our handle and blade. If you break it down even further, what you do want to make sure is, obviously with a rig check or whatever you're doing, is making sure that your handle has batteries that are actually going to light up the light at the end of your blade. I know it seems like a small light, but in the grand scheme of things, if you don't have that light, it's nearly impossible to see what you're doing. And you'll see that it really depends on the blade or the brand or anything like that. Some new blades are even LEDs, so it's a bright white light. Good example. Some people can get tripped up on how the blade itself connects to the handle, and it doesn't connect just straight away like how you see it there. It's really just, you put them side by side, and I think I showed a couple people in skills lab how they click together. Make sure it is fully clicked together before you try to intubate, because otherwise you'll end up losing that blade in the person's mouth. Not saying it's going to go anywhere, but it's pretty frustrating when then you got to take everything back out. You've got to pre-oxygenate your patient again. You've got to have somebody bag the patient back up to where you're at a point where you're ready to intubate this patient again. All right, different types of blades, curved and straight. So our curved blades, does anybody remember which ones those are?
Mac.
Mac, right? C for curved. And then our straight blades are our Millers. Some blades that you might often see, I'm not familiar with the ViewMax, but I am with the Grand View blade. And the Grand View blade is a very wide, I'd say it's almost 2 inches wide blade that essentially just their whole tongue gets covered by this blade, and it's a lot easier to see. It is a massive blade. I'll see if I can find one to show it to you guys, either in person or a picture of what they look like. And you'll see different types of handles as well. Honestly, some handles almost look like a pistol grip. They'll have different imprints for your fingers. It's just a little more comfortable, and you'll see those more often than people that are intubating patient more frequently. In EMS, yeah, we have the ability to intubate a lot of patients, but again, not everybody we encounter needs intubated. There are providers that, and I know them personally, that feel they need to intubate somebody that looks at them wrong, or their protocols allow somebody to intubate somebody that just because they're intoxicated. Is it essentially right? No. But again, that's their protocols. Different types of ET tubes. And I wouldn't even say different types. Different brands kind of determines what the tube is going to look like. Some of them might have a black mark at the end. And I think I've explained to you guys that black mark just is supposed to sit in between the vocal cords. Some of them have that, some of them don't. But they generally all have centimeter markings along the side of the tube. And I'd say on average, we're anywhere between 20 to 26 at the teeth when we're intubating somebody. And you are leaving, obviously, a good anywhere from 10 to 6 centimeters hanging out of the mouth. You never want to see an ET tube buried all the way to the teeth, like the end of it to the teeth, because that obviously means you're too far and you're tickling that person's right lung at that point. Adult tubes all have that distal cuff at the end, provide that seal obviously in your trachea. Pediatric tubes with or without cuff. Some of them do have cuffs and some of them don't. You're actually going to see that move in the direction of all of them having cuff tubes. For the longest time, we didn't use cuff tubes on pediatrics because there was some study that said by us inflating a balloon in their trachea, we're cutting off blood supply around their trachea. We're making it to where necrosis is setting in the tissues, and we don't do that with kids because they're developing. It's been proven wrong I don't know how many times. So we didn't use cuff tubes for the longest time for peds, but now we're going back to using cuff tubes on it. And honestly, the easiest way for a kid to determine ET tube size for me personally, I think the book will say take their age plus is it 2 or 4, and then divide by 4. I'll have to look up that formula. Easiest thing for me is the size of their pinky. If you can find a tube the size of their pinky, then that's generally the size of the tube that you need as far as thickness wise. Hopefully your tube has a stylet. Now, I've been on services before that they ordered tubes and didn't realize that the tubes didn't have stylets on them. So maybe the stylet was separate in the Airway kit, but it's pretty tough to get a tube successfully placed without a stylet, unless you're using something such as a King Vision. So again, it's just another fail-safe. Make sure you have a stylet if you're going to use it, because that allows you to bend the tube around if you need to, or make it look like a hockey stick, or adjust it, especially while it's in the patient's airway. So diagram of our ET tube, obviously open top end. Again, when this comes out of the package, and I told some of you this Thursday, that top end is not always secured to the tube. Sometimes it's very loose on there. So the first thing I do when I open a package with an ET tube in it is I grab the top and I grab the tube and I make sure that I twist and turn them together at the same time, just to verify that it is correctly seated. Because I've had it before where I intubate somebody, I pull the BVM off to hook up end-tidal or hook up a colorimetric device, and I'm now missing that open piece, that top part. And I'm looking around the room, and you can imagine during a code, everything's scattered everywhere. I'm looking around the room looking for this top part, going, where's it going? And I'm ripping open a new tube and grabbing it out of there. to find out that it was actually just on my BVM and had come off with the bag. So make sure that's cinched down on there tight. Your pilot balloon. So that's essentially the place where we are going to inflate our air to insert the air into our distal cuff. Usually when you get that little balloon full of air, that's a pretty good indicator. That is supposed to be an indicator that your distal cuff is inflated as well. That inflation valve is not threaded. I saw a lot of people trying to thread that on there. It's not threaded, it's just pushed on, but you got to push it with a little bit of force. And remember, when you're inserting air, once you're done, pull that syringe off because it will feed back into that syringe and deflate your cuff. Generally 10 cc's or 10 mLs. We don't really use the term cc anymore. It's mLs, it's the same thing. You shouldn't need any more than that to fill the distal cuff on your ET tube. I also showed some of you guys a bougie device. I don't know why people don't use them more often. And again, I think it might be a pride thing, but it's a lot easier to insert a bougie into somebody's airway and then slide the tube down blindly into their airway. Personally, I like them because it's another fail-safe for me. And I'm not in the game of, well, I'm such a good paramedic, I don't need this or I don't need that. But at that point, I need an airway. I don't care about pride. And I think we'll have a chance to mess with them coming up again Thursday night and then Saturday. As far as securing the tube, I had a couple people ask me about tape. You can use tape to secure, just wrap it around, tape it to the person's cheek. Sometimes you'll see a cloth. It's also almost like a shoestring that's split, and you'll tie it around and then tie it around the patient's head. But honestly, what's more often common than not is the commercial devices, the tube securing devices that we're used to, the purple ones that, the tube fits perfectly in. Generally, I leave the opening of that securing device facing up because if I'm sitting in the captain's seat, I can watch to make sure that my tube hasn't moved at all. So if I secured the tube at 22 at the teeth, I can look through that little gap and make sure that it's there, 5-6 minutes down the road. Make sure you have a pair of forceps handy, not just because you need to, pull something out of somebody's mouth as far as an obstruction. Maybe it's a piece of food or something like that. But it can also assist you if you have any problems with the tube itself and are needing to feed it in or maybe even pull it out and it's just not working with you. It's essentially a long set of pliers that has a 90-degree angle. It's really easy for us to use. And then if you need to lubricate it, generally all ET tubes or our airway kits will have lube in them and water soluble. Again, what I do personally, I know don't take this the wrong way, but I use the patient's saliva. I'll run the tube along their mouth, use their own saliva as lube because it's quick, it's effective. I don't have to rip open another package to be able to lube my tube up. Suction. The reason we want suction, if we go in there to intubate and we happen to scrape the person's mouth up, okay, we've got some blood in the airway, maybe we induce vomiting that we need to suction, or maybe it's a patient that has severe CHF and that tube starts filling with, sputum. It's pretty common, especially if you intubate somebody with severe CHF and you're worried about airway compromise or respiratory failure, is that tube will start to fill up. And if you are not suctioning it, you've lost that airway with that patient. And then some form of confirming device, whether it be an esophageal detector, which I'm not a huge fan of, and I don't think a ton of places carry them anymore. There are a select few. It's essentially, to me, it looks like a bulb syringe you use to clean out a kid's nose. It just goes right on the end of the ET tube. You squeeze it before you put it on. If the bulb stays squeezed, that usually means, if I remember right, I believe the bulb stays squeezed, that means it's in their stomach. If you're able to squeeze the bulb open and close without any issues, you're in the lungs. Again, there's some variables, though, that can go wrong with that. Colorimetric devices. Let's see if we got a picture of colorimetric device on here. Yeah, we'll talk about the colorimetric devices here shortly. But again, I'm not a huge fan of them because they rely off an acid. And if that patient has any sort of vomit or anything in their mouth and it catches that filter, it'll pop positive. A colorimetric device, again, they're gold and purple are the two colors on them. Gold is good, was the standard forever. Meaning if you had gold colored on your colorimetric device that you were in the correct placement. If you had purple, it was bad. But again, they're now seeing that those are causing false positives when we're truly not in the airway. The standard of care has really moved towards end tidal and waveform capnography as far as a method to confirm placement. Some of our complications, and I'm not trying to be mean, you guys are new to intubations, and I saw a lot of and heard a lot of clicking of teeth with our mannequins. Tooth breakage is one of the biggest issues when it comes to intubation, is because we don't use the handle like it's supposed to be used, and we almost use the teeth as a fulcrum, and we're pulling back and clicking on their teeth, and we can actually cause it to chip. Equipment malfunction itself, either of the tube or the handle, or maybe you lose your bulb. Aspiration from the patient, again, that's why we have our suction handy. Any sort of elevated intracranial pressure, be a little bit careful with these patients if you're intubating them. That's why, like a drug like succinylcholine actually causes an increased intracranial pressure. So Sux is actually contraindicated for people with increased ICP. We'd have to look at a different drug such as vecuronium or rocuronium at that point. Transport delays, sure, if you have a long scene time or you have a long extrication time. ET tubes aren't meant to be in forever. And again, we're out in the field moving this patient around constantly. So make sure we're double checking. Obviously, if you intubate the stomach or if you intubate one lung instead of the other, instead of both of them. What? Okay, let me ask you this. Hypoxemia is listed as a contraindication. Well, aren't we intubating so that we can correct hypoxemia or correct hypoxia? So why would hypoxemia be a concern?
Insufficient tidal volume.
Okay, maybe insufficient tidal volume. And that could be from a natural disease process such as like cystic fibrosis. But what's another reason that we'd be concerned with hypoxemia?
They're already deprived of oxygen and you're already taking more time.
Yep.
That's exactly what it is. They're already deprived of oxygen. And now we're going to take more time without them having oxygen for us to sit there and mess around trying to intubate them without a guarantee that we'll get an exchange of carbon dioxide and oxygen. So that's a concern as well. Use laryngoscope as an instrument, not a tool. It is an instrument to assist us. That's all it is. I call it a tool as well. It is technically a tool in your toolbox that you can pull out. If I go to put a laryngoscope in somebody's mouth and they start gagging, what do?
Push it farther.
No. That's honestly when I need to back out and now get another game plan. And at that point, it's probably going to be RSIing them and maybe sedating them to the point that I can try. Maybe just a little Versed. Might even take away that gag reflex so where I can intubate them. I've had a number of patients that I haven't had to use a paralytic on, that I give them Versed and I'm able to easily intubate them. But again, you have to be careful, especially if it's a trauma and they've already got low blood pressure. What's Versed going to do to blood pressure?
Lower it further.
Yeah, drop blood pressure. So again, it's another concern. You got to be careful with that. That's why a lot of people are going to ketamine, because you won't see that drop in blood pressure. To avoid hypoxemia, limit each intubation attempt to no more than 20 seconds before reoxygenating the patient. Okay, in our EMT world, yes. In real world, that is crap. And hopefully you guys, when you go to the OR, are able to see. I got my eyes open in paramedic school by an anesthesiologist because I was rushing to intubate this person. He looked at me and he goes, "Why are you in such a hurry to intubate him?" And I said, "Well, I don't want them to become hypoxic, like I'm a genius telling him how to do his job." And he goes, "Stop what you're doing. Take the blade out of their mouth. We're going to sit here. We're not going to bag this patient. And we're just going to sit here and watch their oxygen set." So we sit. If I remember right, the patient was at like 96, 97%. 2.5 minutes had gone by, and we didn't see a drop in O2 sat. And so I'm sitting there kind of shocked, and I'm like, well, how does that make sense? And he goes, well, the body will hold on to oxygen for a while. He goes, just because it's not, you don't have the mechanical process of the exchange of carbon dioxide and oxygen doesn't mean that they don't have a built up store in their blood. He's like, the heart is still pumping. As the heart pumps, it carries oxygen molecules around in the blood. So the patient is still getting some form of oxygenation in that sense. And also, SpO2 is a horrible indicator when we're talking about patients' exchange of carbon dioxide and oxygen. And I don't know, I can't remember if it was you guys, if it was your guys' class or not. I demonstrated by putting myself on end-tidal. It was 5 or 6 minutes after I quit holding my breath that my O2 sat started to drop. But it was within 30 seconds that end-tidal could pick up that I wasn't breathing. It started alarming apnea. I'm not saying pulse ox doesn't have its place, but I'm saying use pulse ox in conjunction with end-tidal monitoring. Again, we want that range of 35 to 45. If they're higher than 45, they're holding on to too much. We need to bag them down. If they're lower, they're breathing too fast. You'll see an end-tidal rating of 20 in a patient that has severe anxiety or is having a panic attack because they're freaking out and breathing too fast. That's when you'll start to see them have those carpal pedal spasms where they start to say, their arms and legs feel like they're going numb. That's generally from the panic attack because you've blown off all your carbon dioxide. A lot of times, apneic oxygenation, what they're talking about there, and I do it when I intubate somebody, is I'll put them on a nasal cannula, 5-6 liters nasal cannula, even if it under the BVM, so that way they're still getting some sort of oxygen when I'm attempting to intubate them. So there's nothing wrong with doing that. You can put a nasal cannula in somebody you're going to intubate, turn the oxygen up a little bit, and it'll help out a little. Is it going to provide all the oxygen you need? No, but it doesn't hurt to do. When we go on our break, I'll see if I can find the article on this. Does anybody remember? Oh gosh, and this is kind of what stemmed it. I can't remember how many years ago it was, but 2 paramedics had intubated a teenager, and they misintubated him. They actually put the ET tube in his stomach and not his lungs, and were bagging him the whole time and couldn't figure out what was going on. They get to the hospital, basically told the doctor, "Oh yeah, we're not sure what's going on." Doctor went to check and figured out they intubated this kid in his stomach. Kid ended up being brain dead because he lack of ventilation. And it wasn't, if I remember right, it wasn't a severe case like the patient needed intubated. It might have even been intoxication, if I remember right. And that really what stemmed the, hey, should we take intubation away from paramedics? And we need to start verifying a little bit better than what we're doing. I don't know how you can't miss that the patient is intubated in their stomach. It's pretty easy. You'll see their stomach rise, especially if you're listening over their stomach with a pair of ears. You should hear some gurgling. And end-tidal, you're not going to get barely any reading at all. And your waveform is going to be almost non-existent. Some other concerns. Any tears in the lung parenchyma, so the tissue surrounding the lung, can cause a pneumothorax. Okay, what's our concern with a pneumothorax? What's truly happening in our chest cavity with a pneumo?
Air is entering the space around the lungs.
Okay, so what's that causing to happen?
The lung to have pressure put on it and collapse.
Yeah, so our lung isn't able to expand because it's got so much pressure pushing against it. So that's where we look at performing a needle decompression. In the hospital, they'd end up getting chest tubes. We do it just to bleed that air out to allow the lung to expand. Now, people can have either a tension pneumo, which is caused by trauma generally, or they can have a spontaneous pneumo, which is generally what you'll see in like taller, thin people. They can just have a spontaneous pneumo for no reason. If you suspect your patient has a pneumo but you're not sure, err on the side of caution if they have a pneumo. Now, am I saying every pneumo needs a needle decompression? No. But the point that you're starting to notice symptoms, yeah, they probably do. Because as that pressure builds up in their chest, you got to think it's going to push on your great vessels of your heart. And what happens then is you're going to start to see a drop in blood pressure. You're going to start to see JBD. You're going to start to see tracheal deviation because of that pressure buildup alone. Okay, obviously orotracheal is through the mouth. They don't really teach cricoid pressure anymore, also called Selleck's maneuver, but it still can be used, absolutely. Locate the Adam's apple in the patient while somebody's trying to intubate them. Maybe it's an anterior intubation, so it's very high. You can actually push down on that area around the vocal cords, Adam's apple, and you can actually bring the cords into view for them. It's pretty easy. When you guys go to the OR, again, be humble because they will eat you alive there, and they're not the nicest people. I get it, but they will teach you some stuff that you will never see anywhere else. And honestly, ask them if they can show you cricoid pressure because they intubate a lot of patients every day. You'll have a chance to see it. Once you visualize what you're going for, obviously insert your ET tube, inflate your cuff, give a breath, listen at that point over your stomach to see if you've got air in the stomach, listen over your lungs to confirm placement bilaterally. Confirm placement with end tidal detector. Secure the tube and then reconfirm that it's still in the right area. Leave them on end tidal the whole time you're transporting them to the hospital. Keep listening to lung sounds. Keep watching that waveform to make sure that nothing changes. There's a mnemonic I wrote down for some of you guys. In the event that things start going south with your intubated patients, and a DOPE is the, I wouldn't say mnemonic, but DOPE is DOPE, and it stands for dislodged. So a dislodged tube, obstructed, potential blockage of the tube. P is for pneumothorax, and then E is for equipment failure. So DOPE is what we turn to when we have a ventilated patient that's starting to go downhill.
Rudy, could you say that one more time?
Yeah, DOPE. So dislodged, obstructed, pneumothorax, and equipment failure.
Thank you.
Yep. Any questions about any of that? All right. Well, that is an old picture. You'll see BVMs kind of like that when you go when you're in the hospitals. When you're in the OR, they're connected to this big machine. You don't hold, the only thing you hold over the patient's face is the mask. And then there's a long tube that goes to the bag. So generally you're standing there, you're squeezing the bag with your right hand and you're holding the mask on with your left hand, and the bag is nowhere near the mask. You'll kind of get to see that when you're in the OR. So obviously they're ventilating our patient. We now see the need to intubate at this point, or maybe they're pre-oxygenating. Preparing our equipment, inflating our cuff, make sure that we have good expansion, that we don't have any issues, we don't have any leaks. Remember, no more than 10 cc's of air. If it takes more than 10 cc's, you probably got a leak somewhere. Inserting our blade into the patient's mouth. And in this case, that's either a Grandview blade or a Mac 4. That might be a Grandview blade because it's really wide. He's got his ET tube ready, and you can see he kind of put the hockey stick approach to it, how it's kind of bent like a hockey stick. So he's ready to go at this point. We're going to visualize the cords. You can see his partner's applying cricoid pressure there. ET tube is inserted. The cuff is inflated. He didn't remove his syringe. Failure on him. He's going to ventilate. You can see one partner's listening for lung sounds. There's your colorimetric device right there. So obviously we have a gold color, meaning that they had good respiration. And they secured it with like a cloth tape. Like I said, they wrap around and then they would wrap around the patient's head. I'm not against that, but again, we have tube securing devices for a reason. Double checking, listening to the lung sounds again, and our patient's intubated. I cannot preach how much you need to listen to lung sounds or how much you need to truly assess these patients once they are tubed, and how much you need to reconfirm and reassess once you intubate this patient, because you've taken that airway from them. You now have to maintain that airway for them. Don't, let your patient down by doing something stupid and not paying attention. Don't become over reliant on technology. And I've said that time and time again. Does everybody's service here carry a King Vision? Is there anybody that doesn't? Or some sort of video laryngoscope?
We don't.
Okay. What do you guys? So you just manually intubate, right?
Or I mean, we're just a basic service, so we just do Kings.
Okay. I don't think I've ever intubated a patient with a King Vision, and I'm not, and it's not because I for one, I don't like them. For two, I don't want to become so reliant on that I lose my manual skills, because in the event that screen or something breaks on that, and I haven't manually intubated somebody in 2 or 3 years, I'm kind of up a creek without a paddle at that point. So don't become reliant on technology. Always fall back to your manual skills. When it comes to clinical condition of the patient is the deciding factor. I always tell everybody, if you have to ask yourself or ask your partner, hey, should I intubate this patient? The answer is yes. If that crosses your mind, should I intubate this patient? They probably need to intubate it at that point. If you think that they're so severe you need to do that, then yeah, let's do it. Some subjective methods of confirming placement of an ET tube. Direct visualization, again. Tube misting, which is kind of crap, and they'll tell you that in the OR as well, is condensation in the tube. If you're in the stomach, you can still get condensation in the tube. So don't rely on that. Auscultation for breath sounds. Yes, after you listen over the stomach. Objective methods. So capnography, those esophageal detector devices, endotracheal tube introducer, such as a bougie, pulse ox, chest rise and fall, and then worsening gastric distension. If you see your patient, their stomach starting to get bigger over time, you probably got a problem, and you might want to check that. Again, fall back to dope, dislodge, obstructed pneumothorax, and equipment failure. All right, retrograde intubation. Not something we're generally going to be doing very commonly, but in the event that we need to, this would be like a quick trach, or you'll even see like surgical airways done like this, which could be either a needle inserted through the cricoid membrane, which we don't get to that as a skill until third semester, to where you've lost the patient's, you're concerned about their upper airway. Maybe it's a anaphylaxis, you are unable to intubate them. Maybe it's due to trauma, you can't verify landmarks. At that point, you would look at inserting a needle into their neck to breathe for them. But the problem is, if like a service I work for, we just carry a 14 gauge or a 10 gauge needle that we would insert it through their neck or their cricothyroid membrane. The problem with that is, imagine taking even a 10 gauge needle, attaching a BVM to it, and then breathing. There's barely any air movement. That's where you need to hope your service carries some sort of quick trach device to get a much larger diameter tube in place. Has anybody seen a trach done before by chance in the field? Again, it's not a common thing. I only saw it once, and it was in the hospital. It wasn't in the field. Air trachs, they're kind of, they're disposable, and you also have disposable laryngoscopes that they're one and done. So once you visualize, once you get the ET tube set, you can actually get rid of that whole device itself. You'll also see some stylettes will have, especially in the hospital, have like cameras or lights on the end of them that they'll use as well that they'll throw away. There's a McGrath, which we actually have one at the college. Again, I don't let you guys play around with it until you're later on in your paramedic school career, because I don't want you to become reliant on using that for intubation. But we do have one. I can show you guys if you haven't seen it yet. It's pretty cool. They're about $3,500, $4,000. We received it from a student in the last class who actually works in the OR at Methodist. So how do we initially improve success, first time success when we're intubating our patients? So good initial training. By God, I hope I'm doing that. Ongoing practice. Well, at least throughout the next year, you guys will be practicing this nonstop. Using a bougie if you have one. Proper positioning of the neck, and I'm not talking about don't crank their head all the way back because you can't see what you're going for. And they'll tell you this in the OR. You should not have to bend down when you're intubating somebody. If you're standing up and the patient's on the table, you should not have to bend down. You should be able to see everything just by looking down with your head. Video laryngoscopes. Excuse me. Video laryngoscopes obviously are going to improve our success rate because it's a little bit easier for us to see. And then making sure we're practicing RSI. We're knowing our drug dosages for RSI, our indications, our contraindications of those drugs. It's all stuff that we should be practicing on a regular basis. Even with your service, I don't know any service that doesn't have an airway trainer head or can get their hands on one. Blind nasotracheal intubation. Again, this is a skill we're going to go through, I believe, later this semester. They use this a lot in conscious patients, honestly, because I would say in the OR, they use it on conscious patients. If we're doing it, the patient is unconscious, but they still have to be able to breathe, because once you're inserting it through their nose, they have to be able to inhale for you to insert this. And it's a lot bigger tube than you think. You know, generally, I think I told you guys anywhere between 6.5 to 7.5 is what I use orally when I intubate somebody. I've seen nasotracheal intubations done with like an 8.0, 8.5 tube. And again, we'll show you guys how to do this and how to make sure that you're in the correct area. Trauma patients, we're not doing this because we'll, again, ventilate the brain, but not in the way that we want to. And we'll cover that in skills lab. We used to, when we talk about digital intubation, we used to just blindly intubate people, and it can still be done. And when they say digital, they're talking like digits, fingers. We would actually use our hands and put our fingers in the person's mouth to intubate them while feeling for structures. The only time you would blindly intubate somebody that I can think of, and I've only ever, again, seen it done once, was a car accident. The paramedic laid on the hood of the car. The windshield was cut out, and he had to intubate the patient in the driver's seat. So he had to blindly, I call it ice picking, put the laryngoscope in their mouth, pull down on it because, again, he's upside down, feed the tube in, and then he put end tidal on to see what he was doing because he didn't really have any other way of visualizing or confirming placement at that point. And I think it took him a couple attempts, but he did end up getting it. But otherwise, we don't really do this, and we don't really put our hands in patients' mouth anymore. There's an example of it right there. Blind insertion, but you're going by feel. So essentially, you're feeling for the epiglottis. You're holding the epiglottis up with your index finger, and then just allowing the tube to follow the path that your hand is. Hopefully you got small hands. Some of our special considerations when we talk about intubating patients: difficult access to that patient. Maybe this is a patient that we can't, that's in the bathroom between the tub and the toilet that we really can't get to intubate. If we have to extricate this patient, how long ago was it? Had to be 2-3 years ago at this point. Somebody I know, there was a car accident south of here, and they actually ended up intubating the patient in the car as well, just due to how long it was going to take to extricate them out of the car in the severe pain, and they wanted to be able to make sure that they were going to maintain this patient. Blood in the airway. That's why it's important that we don't scrape up the airway as well, because we don't want to introduce any blood, because figuring out where it came from might be a little bit difficult. If you're not able to tell anatomy as to where you're going, how can you truly intubate somebody at that point? Need to protect cervical spine. If they got a C-collar on, it's horribly hard to intubate somebody, and you guys will get to practice that as well. Personally, if somebody has a C-collar on, I'm going to intubate them. I'll have my partner hold C-spine. I'll take the collar off. I'll have him hold their neck the whole time while I'm intubating them at that point. So this is going to be intubating somebody, as I just said, that's being inline maintained. We don't really want to move their neck around the whole time or really crank their heads back, so that person still maintain good posture with them. They might have to get a little bit lower, again, because we're not able to move their head around a whole lot, but we should be able to see good visualization either way. Might have to really use that cricoid pressure there. I think it was your guys' class. I showed the video of night watch and the person choking. Then we got them in the back of the ambulance, and they used a laryngoscope to essentially put it in the person's mouth, lift up to see what they were choking on, and use the forceps to actually pull that hunk of meat out. Was that your guys' class? I showed that too?
Yes.
Okay. And there's nothing wrong with that. You have a patient that's choking so severe you're not able to see what's going on. Use your laryngoscope. Use the tools you have. Get in there, open up their airway. Their gag reflex is gone at this point because they're already choking. And see if you can see what it is, and use your McGills to pull it out. Just as so. I had a doctor tell me once, because I always ask, what if I cannot get out what they're choking on? What do I do? And he goes, honestly, push it down further. He goes, because eventually it's going to go into just one lung. He goes, and one lung is better than nothing. He goes, we can go in and do surgery to remove something from a lung. I can't go in and do surgery to make this, to bring this person back to life, because they choke and weren't able to breathe, essentially. So, and that's always stuck with me. If I have something stuck in somebody's mouth to where I can't get it out, I might have to push it down further, because again, I can at least get ventilations at that point with one lung. Kids are difficult. They got structural issues that we don't. Everything inside them is growing. They don't even have cricoid rings inside their trachea like we do. You won't feel those bumps going down their trachea. Small nose, small epiglottis. Their airways are real narrow. To be honest, they don't even let you intubate peds at the hospital in the ORs. If it's a surgery with a kid, you guys aren't allowed to intubate them. And we generally can't use a surgical airway on a kid, because we can't identify anatomy, because everything's growing at that point. Cricoid pressure can worsen the situation because their tracheas aren't as stiff as ours. So we could actually be causing more harm than good when we're doing cricoid pressure on them and actually collapsing it to where we're not going to see it at all. Remember, they're growing. They're little people. They don't have fixed structures like we do. Everything is growing inside them. Tube size critical. Again, we didn't used to use cuff tubes for them. That's gone out the window now. We do use cuff tubes for peds. Depth of insertion, do the same as you do for an adult. Just enough to where the cuff is past the vocal cords. Their epiglottis is compared to the rest of their airway is huge. I mean, compared to ours, it's small, but compared to everything else in their mouth, and so is their tongue. So you got to be careful as far as moving things out of the way. Occipit, relatively large. Who remembers what from ENT school what occipit is, or the occipital region? It's the back of your head. Kids have that giant head, so that's why them laying flat can actually cause more of an issue. That's why we generally pat underneath their shoulders to bring their airway into more of a neutral position. If you're not sure on the ET tube size, honestly, use your Broslo tape. It's there for a reason. It'll tell you tube size. It'll tell you what blade size to use for that a kid that's average of that size. Use it. Seriously.
Rudy, I have a question.
Yeah.
How do you determine what blade size you use for an adult?
It's really preference. Like my preference for every adult, I don't care who it is. I use a Mac 4 on everybody because a Mac 4 is a little bit thicker and it's the longest blade you can get in a curved blade. And the only reason I use the longest one is because I can, if the blade's too big, I can pull some out a little bit and still be able to use it. If I use a shorter blade and I don't have enough to reach the epiglottis, then I have to stop, change out the blade. So it's really just a preference thing when it comes to size. Obviously, you're not going to use like a Mac 1 on an adult. Generally, you'll see like Mac 3s and 4s or Miller's 3s and 4s used on adults, but there's no set number for them. Kids' airways, their narrowest part is their cricoid cartilage, so right underneath Adam's apple. So seeing things isn't going to be as easy as it would an adult. To be honest, I don't think I've ever looked inside the airway of a peds. It's not something I ever want to do, is have to intubate a kid. And if you've ever tried intubating on our little mannequin head we have, you know it's hard. See if we've obviously got a demonstration here. So ventilating, pre-oxygenating this child. We've got an uncuffed tube there because we don't have that little balloon at the end. And you can see the black mark in the end of the tube there, so that part just needs to go past the vocal cords. Blade is inserted. This is a tough little kid if they're going to intubate him. Equipment prepared. Tube placed. And then obviously it's going to be the same as an adult at that point. We're verifying. You can see they have end tidal hooked up right there. I don't know if I would have volunteered my kid for that. I'm kind of shocked they have that.
I bet if you look at hand placement on all of those pictures, that tube is along their hand and not in his mouth.
Well, that's what I was trying to figure out. But right here, you can see it going in his mouth. And even that blade, I don't know. I don't know. Either way. All right, let's take a 10-minute break, and then we'll come back, finish up our slides here. We don't have a whole lot of slides on this, and then we'll talk a little bit about that worksheet I signed you guys. So take 10 minutes. All right, let's come back and finish it up. All right, so what we're talking about here, monitoring cuff pressure. We're talking about the cuff that at the distal end of the ET tube. For us, it's not a huge deal unless we're worried about leakage. Just making sure you're looking at your little inflation valve and making sure that balloon around that is inflated during the whole time. The only real issues that I could see with monitoring cuff pressures when we're talking about like flight physiology or something like that. And even then, we'd have to be at an altitude that's really high. That's why you see some places, if they're going to intubate a patient and take them on a flight, they might use saline instead of air just due to gas laws. You won't see that shrinkage of the cuff and to where you could potentially lose the airway. But if you have any issues with the cuff pressure itself, you probably got a leaky tube and probably need to swap it out for a different one. If your patient, if you RSI a patient and they wake up or start to wake up on you, that's bad. That's bad because we can't extubate in the field. We don't have the ability to pull that tube out of somebody that starts to wake up. That's not something we do. We don't have protocols for it, nothing. Even in the state protocols, generally we just need to sedate that person at that point. Now, if you are using end-tidal, and this is something I'll show you guys in skills labs or in person or something like that, you can actually tell if a patient is starting to wake up about 5 minutes before they do, based off their breathing patterns. It's what's called a Curare cleft. And it is essentially on a waveform where you're seeing a big square. You would see a square with a dip in the middle of it. That means the patient is starting to overbreathe the tube and they're starting to come to. Again, that generally happens anywhere 3 to 5 minutes before they actually do gain consciousness. So using end-tidal to assist you with that and making sure your patient doesn't wake up is pretty important if you can. Again, we're not doing that in the field. Needle crikes. So kind of talked a little bit about this a little bit. If I need to somehow gain access to the patient's trachea by means of a quick trach, by means of just a 10 gauge needle with a 2.5 ET tube top on it. That's the only ET tube top that'll fit in a needle is a 2.5. What you might see used, because again, it's so little air that comes out those needles out that catheter, is they'll use what's called a transtracheal jet device. And it's actually like a ventilator. You used to see them on our AutoVent 3000s when those were a thing. They'd actually hook up to the ET tube and they'd force air in to fill up the person's lungs with this jet ventilation system. Open crike is a little more leaning towards our surgical at that point. Just for the simple fact that it's a little difficult because we're using a scalpel at that point, and Iowa's paramedics are not allowed to use a scalpel when we're talking about crikes. At that, we have to use what is called a quick trach or a needle. Now, the CCP endorsement in Iowa allows you to cut through that cricothyroid membrane with a scalpel to where you can actually insert an ET tube down into the patient's trachea if you need to. It is highly invasive because you're cutting through not just tissue, you're cutting through part of their trachea to gain access at that point. Some of our landmarks, if we're going to do a needle crike, it's easy if I show you guys in person because once you do it on yourself, but if you feel your Adam's apple, let me get my pen out here. So if you feel your Adam's apple right here on yourself, and then you go down, you'll actually feel another hard part right here. Well, in between your Adam's apple and the part that's hard below it, you have what's called your cricothyroid membrane. This little area of soft tissue right in between two hard parts. That is where we look at inserting a needle, or if we have to cut, that's where we look at cutting, is that cricothyroid membrane. You don't want to hit your thyroid gland because that's bad juju. You could actually do more harm than good with your patients if you were to hit that. So we're looking for that really soft spot in between the two bumps in our trachea. It generally hurts when you push on it. Now, this could be a challenge if you have somebody that's maybe a bigger person or you can't identify landmarks, and that's a contraindication to doing a crike, is an inability to identify landmarks. On somebody like my size, it's going to be nearly impossible unless you flex my head all the way back to feel the correct landmarks. So you got to be careful with that. And I'll show you guys the jet ventilation as well in person. It's not going to be sterile. You want to try to keep it as clean as possible because it is, again, a very invasive procedure. But generally, if you're going to do a needle crike, what I would do is actually take the cap off the back of your needle and hook that to a syringe of saline. And then when you puncture, you'll actually see air bubbles come up into the saline, showing you that you're in the right place, and you can actually withdraw air at that point. That's another, and there's so many different ways of doing it. And again, we don't really get into that until PHTLS with trauma. So that'll be, I believe, third semester or late second semester when we start doing needle crikes. And then we get to do them on pig tracheas. There's the transtracheal, what I'm talking about. So you have a trigger. Once it's hooked to this needle right here, they did a needle crike, they've secured it. They put this tubing right onto the end of the needle, right onto the catheter. Once they push that button that injects air, and they're just looking enough for chest rise, and then let go of the button. And then it will automatically suck air out as well at the same time. It's a very complicated process, but it's very simple to use, to be honest. And again, we'll mess around with one of these in person. We have one at the college. Open crike, it's again the same as surgical. I'm not going to beat a dead horse by talking about that 30,000 times, but let's see if we have, yep, here we go. So right here in between our cricoid membrane and our thyroid membrane, we have our cricothyroid membrane, this little soft spot right there. So we're feeling for that. We then, at that point, create a cross, almost going over it. So if you're going to use a scalpel, you create a vertical incision, and then you create a horizontal incision. Then generally you use like forceps to actually go in and spread the skin open where you can visualize the trachea. And then you would puncture down through the trachea with a scalpel. Once the trachea is punctured, use your forceps, go in there to hold your trachea open. You would then feed your ET tube through, as shown, until it is in far enough to where we can ventilate our patient. Another good thing is, once you get it put in there, you can actually use a bougie to insert your tube. Only seen this one done once in the field, to be honest. And it was just because the guy had a stoma, and it had actually fallen, or I don't know if it fell out or got displaced or something. And they lost positioning of it. So the paramedic that I was with at the time flew for many years. And so he decided that the only way to get it back in was to recut and put an ET tube in at that point. There's not as much blood as you'd think. Yeah, there's some vasculature above the skin right there, right above the trachea, but yeah, it'll bleed somewhat, but you're not going to see a massive amount of blood or anything like that. You're right over the trachea. There's no concern about hitting a jugular vein or anything like that. So as long as we're talking correct positioning, and again, this is something that I'll show you guys and demonstrate for you at the college as for skills. All right, drug-assisted or rapid sequence intubation. So we have to generally, this is used for a patient that has a gag reflex, or maybe a patient that's altered and can't protect their airway. Maybe it's an overdose, they can't protect their airway, and we need to essentially sedate them, use a paralytic to stop any neuromuscular function to where we can get a successful intubation. Now, let me ask you this. in what order would we push our drugs? Does our paralytic go first, or is our paralytic last?
Last.
Why?
You don't want them paralyzed and still awake.
Yeah, exactly. You don't want them paralyzed and still awake. A lot of protocols, and I'll say refer to your own protocols on this. A lot of protocols you might have to pre-medicate with fentanyl, and then from fentanyl you might give etomidate. And then after the etomidate sets in, then you would give your Sux or Rock or Vec or whatever it might be. And then you would probably just keep the patient down with Versed. So every 5 minutes, every 5 or 10 minutes, you give them, excuse me, every 5 or 10 minutes, you'd give them another 5 milligrams of Versed just to keep them sedated at that point. Some of our concerns with intubation, as far as oxygen reserve with our patients, obviously elderly people don't have the same lung compliance they did when they were younger. Obese people as well, because they have a lot of tissue that's pushing against their lungs at all times. Pregnant patients with lung disease, such as COPD, that cystic fibrosis, any sort of chest trauma. So maybe it's a flail segment, a broken rib that's potentially not allowing good expansion. Or maybe they're just a hypoxic patient as it is. You'll see that a lot of times with our COPD patients that, sit in the 80s, and that's their normal. We leave them at that because they rely off that hypoxic drive. We knock that hypoxic drive out by putting them on 15 liters of oxygen, and we've actually created a patient that's going to go into respiratory failure. Things that increase oxygen consumption: fever and sepsis. Why? Because our metabolism is trying to work overtime at that point. Severe pain, because people tend to breathe a lot faster when they're in pain. Alcohol withdrawals. Why would alcohol withdrawals cause oxygen consumption? You may know.
Like the DTEs or whatever they're called.
Yeah, the DTs, delirious tremens.
Yeah. So
as their body shakes, you got to think that's using up energy. That's using up oxygen. It's the same with a seizure. Cocaine, meth intoxication, because we're increasing our heart rate. As we increase heart rate, we increase oxygen demand to the heart. Tachycardia, the same thing. Shock, maybe it's blood loss. So if we lose so much hemoglobin to where we're not able to maintain that oxygen level that we need is a concern. And then kids naturally breathe faster. A lot of kids, if I sent a kid running right down the street right now and then put a pulse ox on them afterwards, they could be in the 70s because kids just don't know when to stop. If I run down the block right now as fast as I can and get to the end, I'm probably gonna be dead. So kids can really compensate for so long before you really know something's going on with them. When we talk about reserves of oxygen in our patients, if you ever hear the term adequate reserve, we're referring to a patient that I would say is between, I'd say 94 to 90, between 94 and 100%. I don't like patients that are 100% because we can't measure anything past 100. I like the number 99. Limited reserve is anywhere 90 to 97%. And then no reserve, patients below 90. This is our COPD patients. It's a little bit of a concern if we have to intubate somebody with COPD because, again, those are the patients that probably aren't coming off the vent. And if you're intubating somebody just for pulse ox, you might want to look at something else. Maybe CPAP, maybe medications before you really turn to intubation at that point. I've seen patients seriously that were like, I would have thought were dying, ghost white, pale. We put them on CPAP as a last resort before we intubated them, and they turned 100% around. So, and that's what CPAP. When you see CPAP put on a patient, it's generally like, hey, this is the last thing before I put you to sleep. Put a tube down your throat. Common medications, if we're going to pre-medicate a patient, again, just to kind of relax them in the beginning, you might see fentanyl given. Quick question, why do you think we would give atropine? Atropine speeds up the heart. Why would we give atropine potentially? And you'll see this in some patients, in some protocols. Why would that be given, a drug to speed up the heart?
Opens airways.
Okay, what else?
What couldn't it be given because some patients, once you knock them down to intubate, it could slow their heart rate way down?
It could, but also you can actually trigger the vagus nerve by sticking something in somebody's throat. You can cause them to vagal down. So a lot of times that's giving as a precaution to just knock their heart rate up a little bit in case that does happen. You see that more often with pediatrics than anything. And then lidocaine. Why would we give lidocaine? Conscious innovation. And I'll show you guys a video on that after the slideshow. You can give lidocaine to numb up the airway. If it's in your protocols, to numb up the airway to where they can intubate successfully without the patient having to be asleep. Then we would look at some sort of induction agent. So whether it be a sedative, whether it be a hypnotic, whether it be a dissociative. Etomidate is classified as a hypnotic. Some will use midazolam, so benzo or Versed. Ketamine has become more popular because it is a dissociative. And then propofol you'll see more common in the hospitals to sedate people, and that's more of a long-term sedation if they're giving propofol.
Rudy, is that just back to that slide? Sorry. Are those just kind of like a what you prefer type of thing to give?
It's really just protocol based.
Okay.
Because like my protocols at one of my services give me the option to use etomidate or ketamine, and at that point it's just preference.
Okay.
What I feel safer with. Our sedatives most often are going to be benzos. So we've got midazolam, diazepam. You do have etomidate and ketamine in there as well. And then your dosages for each. Your onset time for how long before they truly kick in, and then about how long they last. Neuromuscular blocking agents, paralytics, competitive depolarizing. Remember, there's a difference between depolarizing and non-depolarizing. Depolarizing, we're looking at sucks. Now, you got to be a little bit careful because sucks does have a wide variety of contraindications, such as any neuromuscular diseases, muscular dystrophy, MS, myopathies, Guillain-Barré syndrome. If the patients have a prior stroke, because again, this increases ICP, Parkinson's disease, tetanus, I believe malignant hypothermia. So this is, sucks. This is why a lot of people don't carry sucks anymore, is because the number of contraindications that it truly does carry, as opposed to rock or vec, which don't have nearly the contraindications that sucks does. But rock and vec generally tend to last a little bit longer. So if you've got a little bit longer transport time, great drug for that. If you've got a 5-minute transport time, not the greatest drug because they can't assess that patient and they've got to wait till they start to come to. And then what do we use after the patient is asleep? We want to keep them sedated. They're already tubed. We can use narcotics. You can use fentanyl. You're going to have to use really high doses of it. Benzos such as Versed, you'll see that more commonly. And then again, in hospital for prolonged sedation, they're going to turn to propofol and put them on most likely a propofol drip. So when we're looking at RSIing somebody, first step, number one, we pre-oxygenate our patients. So we bag them to make sure that we're getting good ventilations, protect the C-spine if applicable, position the airway, apply coracoid pressure. I love this one. Ponder to decide if we're making the right decision or not. Pre-medicate, again, with maybe some fentanyl. Allow that fentanyl to kick in, start getting your stuff put together. At that point, we're going to sedate our patients with our etomidate, with our maybe Versed, maybe ketamine, and also give our paralytic. Go ahead and intubate the patient. And then we would look at post-intubation management and making sure that our patient stays sedated with either some sort of narcotic pain med, such as fentanyl or Versed or propofol. Worst comes to worst, and you're not able to get that, use a king. And then just keep them down. If they're going to start to wake up, keep them down with Versed, even with the king in. It's not going to hurt them. When we talk about difficult airways, this is the things we're talking about is difficult ventilation, difficult ability to maybe put a king in. Difficult intubation is what you'll hear most commonly. Difficult crike. I've never heard of an easy crike. And then a difficult airway entirely. Just it's maybe the patient's obese, maybe they've got severe facial trauma, facial hair because we can't get a mask seal. Lack of teeth, I don't see that as an issue because it's one less thing that could nick going in. Malampati grade 3 or 4. I want you guys to research Malampati and look up your different scores. Grade 1 through 4. Grade 1, I really can't see a whole lot of the airway. Grade 2, I can start to see some coming into view. 3, a little bit more, and 4. Or I think it's the opposite way, sorry. Grade 1 is the best, grade 4 is the worst. And a lot of that is based off of tongue size and the size of the airway. I've seen people that seriously were over 300 pounds and they had the smallest airway possible. I don't know how it happened. So that's your homework from me. Malampati score. Limited mouth opening. When they have a small mouth. Secretions have suction ready. If we're talking about burns, that patient needs intubated fast because you're going to lose the airway. Trauma, again, probably sooner than later for the intubation. Angioedema, so severe swelling of the tongue. Maybe it's a severe case of anaphylaxis. We'll talk about crikes when we get to that. Oh, well, I was going to make you look it up. All right, so class 1 through 4, you might also hear grade 1 through 4. Grade 1, tonsils are clearly visible. You can almost see straight down their airway at that point. Class 2, the upper half of the tonsils are visible. Class 3, only the top of the mouth and hard palate are visible. Class 4, only the top of the mouth is visible. Nothing else. So class 1 being the easiest, class 4 being the hardest intubation. Let's see if we got pictures. No, we don't.
We do in our book.
Do you? Okay, good. Oh, there we go. So class 1, again, being the easiest. I've got a great view of the airway. Class 2, still not bad. Class 3 is worsening. I can't even see. I can barely see down the airway at that point. And then class 4, I got nothing besides a hard palate at that point. And it's going to be the same if you're talking grades for the area surrounding their vocal cords. Remember, this is our vocal cords right here. This is the view we're looking for. Those 2 white fibrous bands. We're looking in somebody's airway. That's a perfect view. Grade 2 still isn't bad. Grade 3, not so good. And then grade 4, I have nothing I can see. Grade 3 and 4, they're going to be hard intubations if you can get them. And those, the bottom ones, when we're talking about your airway, that's your Cormack and Lehan scale. So top is Malampati. We'll put an M for Malampati. Bottom, Cormack and Lehan. I think I went over this with you guys. So lemons, when we're going to intubate somebody. So L for look, E for evaluate, M for Malampati score, O for any potential obstructions such as the tongue or dentures, N for neck mobility, with this patient? Are you able to move their neck? And then S is for saturations. So maybe you need to suction this patient before intubating them. S was just added recently. It used to be just lemon. So we've got saturations, which covers obviously secretions and also pulse ox. So if anybody ever asks or you see on a test question lemons, this is what they're referring to. I'll be honest, and I can say it because I'm a bigger guy. We're horrible, horrible, horrible to get airways on, just because our anatomy doesn't make it easy on anybody, and we tend to have kind of short and fat necks, and it doesn't make it the easiest when you're looking in the airway trying to see if you can see the vocal cords. And the other concern with that is this right here. Extraglottic airway devices. So our King LTs, our LMAs, our iGels might not generate enough pressure to lift the chest because we have so much weight that pushes down on it. You can tell, you'll get to the point where you can just tell by looking at somebody and they're going to be a difficult intubation just based off their neck size, based off their mouth size, based off facial hair. You can tell just by looking at them. All right, I'm going to pull up a video I want to show you guys in regards to intubation. Can you guys still see my screen?
Yes.
Okay. And let me know if you're able to hear this. Can you guys hear the music or no?
No.
Give me 1 second. Let me change my settings. I might not be able to share sound with you guys for some reason.
Didn't you show us the night watch video on here?
No, that was my old computer from Mercy. On this new one, I don't think I can. Do you guys have a share button on your screen by chance where you can share content at the top?
Yes.
I want somebody to try going to YouTube and see if you can find that video. Just type in awake intubation, and it should be, let me see if I can get back. It should be like a doctor standing there with a glide scope in his hand.
I have it pulled up, Rudy. What do I have to do now?
Try hitting share screen. All right, so go ahead and expand your screen out. And go ahead and hit play and see if it's coming through. Same thing. I can't hear it.
I can play around with the settings too.
Oh, wait, I figured it out. Let me try this now. Okay, can you guys see that?
Yeah.
Can you hear it?
No.
You can't hear it at all, you said?
No, nothing.
Well, I thought I had it. Sorry, my bad.
Can you just share your screen and play it, and then somebody press play at the same time and unmute their mic?
I hear it now.
Okay, good.
I would like this video to throw some light on awake oral endotracheal intubation. There are many situations where an awake intubation is a useful technique, or perhaps even the standard of care. For example, a patient with angioedema affecting the upper airway may benefit from an intubation performed awake. Administering a syringe of propofol or etomidate will cause unconsciousness and may aggravate airway obstruction and certainly leave the airway unprotected. Administering muscle relaxant will stop spontaneous breathing, and as a practicing anesthesiologist, I always consider keeping someone awake and breathing as a priority and a possible plan A.
At the cricothyroid membrane, everyone feel there. So the top of your neck, the top bump is the thyroid cartilage. That's the notch. And then when you come down a little bit, you're going to, before you get to the cricoid cartilage, you're going to get to the cricothyroid membrane. Nothing's there. I do it every year. So, alcohol swab. Ready? Needle goes in. We just sit there for a minute, and, well, 2 seconds. He'll withdraw bubbles slowly.
So he's withdrawing bubbles to make sure he's in the trachea.
And then just get the 3 cc's in and pull out. Perfect. Yeah, because you want to spread it around the trachea. The next thing we're going to do is I have 5 more cc's of lidocaine, and this will go on the fibroscope. And this way we can spray structures as we see them.
So you can see his vocal cords there.
Mm-hmm.
Spraying lidocaine on him to numb him up.
Okay, so we saw the cords and sprayed them. And we'll get started again. Mm-hmm. 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 Mm-hmm.
So you can see we're in the trachea now. Each one of those is a cricoid ring going around the trachea. And then you can actually see where his lungs branch off right there, the carina.
The point behind this is that awake intubations can be done right in front of your eyes. There was nothing magical today. In general, this is pretty straightforward, basic technique.
I just want to point out that I think he's insane. I'm not saying it's a cool video, it is a cool video, but I think he's insane.
I second that.
All right, let me see if I can get something pulled up here for you guys. Who's even started that medication sheet that I posted for you guys and sent to you?
I tried to.
Who said that?
Ethan.
I have
Okay.
it printed off and staring at me.
Okay. Okay, let me ask you guys this. Would you rather go through it in person then?
Absolutely, 100 times yes in person.
Okay. Okay. I think Liam and Cheryl are coming up to Mason City this weekend. And Liam, I hate to say this, but he'll tell you the same thing. He's very good at math because he's Asian. And he teaches the exact same method I do as far as fluid. But, and again, I'm not going to grade you guys on this worksheet. I want you to learn it more than anything. So we'll try to fit it into lab this Thursday. I can't guarantee it because we have a lot to do this Thursday. And same for Saturday, but we will absolutely try, and maybe I can have him use this as med math because I know he's going over med math with you guys this week. Maybe I can have him use some of those from the worksheet. It might help a little bit if I can, because next week for class, we're doing nothing but clinical orientation. So we're going to go through our clinical handbook to get you guys prep for clinicals and field. Let me see if I can figure out a way to record a video of me doing the problems, maybe on a board or something like that. And then we'll watch it together. And after each problem, I'll answer any questions on it or how I did it, if that makes sense. Because I think it's going to be kind of tricky to do it online, to be honest. It's going to be I think it's going to make you guys feel worse about it, to be honest, if I can't show you how to do it in person. All right, Airway wise then. Any questions on Airway? Again, we're going to be practicing intubation this week. We're going to be practicing all skills this week. We're going to be doing every skill. We're going to be doing more IVs. We're going to be doing more med pushes, more med math, more intubations. Everything we've covered so far, we're going to be doing in different stations Thursday night. And it'll make a little more sense, once going through these chapters, we know what we're kind of looking for anatomy-wise. And I don't expect you guys, again, to learn everything from this short little PowerPoint. You have your books for a reason. You have to study that. These PowerPoints do not cover everything that's in that chapter. And you'll learn from anesthesiologists in the OR. You'll learn from different people in the field. You learn from different people in the hospital. Maybe it's even an ER doc that tells you a little bit. What questions do you guys have Airway wise? Pretty straightforward because I know we covered some of the stuff in person already.
Hey, I guess Rudy, last week in the hands-on portion, the instructor that was there, he told us when we're opening the mouth to intubate to use the finger scissor method. Is that true? Okay.
Yep. You cross your fingers like an X and then open them.
Yeah.
Yep. That's correct.
Okay. He just wasn't sure himself, so he was just said to check with one of you guys.
Yeah. We still do that. Who was it? Do you know who it was?
I think it was the guy that came from Cedar Rapids area. I think.
Okay. Mike Stanton.
Yeah.
Yep. Okay. Yeah. No. Yeah. And they'll even teach you that in the OR as well.
Okay. Yeah. He was pretty adamant about it. He just said to check with you guys beforehand.
Yep. Not a problem. And again, I'll be there Thursday night. We're gonna spend some time on intubation. So I apologize I couldn't be there this last Thursday. I was gone for unforeseen circumstances. Well, foreseen circumstances, but wish I could have been there. Any other questions covering Airway? It seems like you guys are getting the gist of everything we've covered besides med math, and I'm fine with that. Because again, I don't expect you guys to, build Rome in a day. I don't expect you to 100% understand med math yet. But what I do want you to start doing is getting those drug cards finished, or getting to a point where you can start studying some. And even, I don't mean finished, but start, if you haven't started them, I'd start working on them immediately. and getting to a point where you can start to review them. How I memorized my drugs, honestly, was I did one a day. And then the next day I would have to recite that first drug back to myself and then look at the card and see if I got it right. And then I would move on to another one and just keep studying that till I had it stuck in my brain. That's how I did it. You can do it whatever way you want. If you want to make flashcards, if you want to do whatever you want, but as long as you have those drug cards with that pertinent information on them. Was it Natalie? Did you send me your cards in an email or a card in an email by chance?
Yes, I did.
Yours was awesome, by the way. Like I really wanted to post it as an example, but didn't want to do it without your permission.
Go right ahead, but I will say that it's very time consuming.
Yeah. Oh yeah, I know. And again, you don't have to type them. You can handwrite them on an index card, however you want to do it. But I was asked today, where do you guys get the information from, as far as dosage wise? If you want to use your protocols, I'm fine with that because your protocols have been signed off by a doctor. If you want to use, your book will have some medications in it. I'm fine with that as well. If you want to use these PowerPoints, I'm fine with that. There's so many different places you can pull the drug dosages from.
Rudy, I noticed when looking at like Hippocrates and RX, is it RX drug?
Yep.
Something like that. That sometimes they're different on their dosage.
Yeah, and that's a lot of those dosages. The only problem with some drugs on there is that their dosages aren't really meant for pre-hospital is the problem.
Okay.
So their dosage will be different than ours until we look at drugs like epinephrine or amiodarone, like ACLS drugs that are common the dose is the same worldwide because it's endorsed by the AHA. That's where on those drugs I'd probably refer your protocols on them. And if you're having trouble finding information on a certain drug, let me know and I'll find you guys the information and send it to you.
Thank you.
All right, any questions?
Did you say those are due at midterm?
Yes.
Thank you.
You've got a couple weeks.
Rudy, did you see the message I sent you on here last week?
What'd you say? I don't think I did see him on Teams.
Yeah.
No, I did not.
Well, what the heck? All right, maybe I didn't send it and I was just imagining it. Let me.
Any other questions besides Andrew? All right, next week again, we're doing clinical and field handbook. We're going to look over I'm going to go dive through the handbook with you guys and explain everything and explain what is expected of you as a student in the clinical and field settings. Because again, once you have your Castle branch and everything done, we'll be to the point here shortly where you guys can start signing up for clinicals, and I'll explain how you do that and how you go about everything. And we'll have some free time next week to cover anything that you want to go over or that you feel you need a little more practice on. If you don't have anything for me, have a good rest of your night. We took about 2 hours of time. Like I said, I'll try not to keep you guys here very, very late every night if I don't have to. If you have not taken your test, it is due tonight at midnight. So please, please, please get your test done. And then I did change the setting to where you guys should be able to go back and see your scores. If you're not able to, shoot me an email and I will tell you which ones you missed. Other than that, Andrew, if you want to hang out on here or try to send me another message, by all means. But otherwise, you're free to have a great rest of your night, guys.
Do you have any other good study preps for pharmacology? Because I'll admit I did not do good on that test when I took it yesterday.
Yeah, and actually, I can email you some worksheets that'll help you that you'll have to look through in the book and fill in the blanks, if that would help you at all.
Yeah, that would.
Okay. Yep, I'll email them to you.
All right. Thank you.
All right, Rudy. It's not a major important question. I just want to make sure I heard correctly. Is our midterm really open book?
Yeah.
Oh, okay. I missed part of it, and I just wanted to make sure I was understanding correctly.
Yep, it'll be open book.
Okay. Cool. And then I didn't get your email of your drug card sample.
Okay.
So can you send that to me?
Yeah. Yep. I actually should have it uploaded on D2L.
Oh, really?
I'm looking right now. Yeah, if you go to like under content, under medication info cards, you'll see like drug card example, and that's actually the drug cards that I made for paramedic school when I went through.
Oh, okay. Cool.
So,
Alrighty, that's all I needed.
all right, sounds good.
Thank you.
Mhm.